I'm going to look a little more specifically about drugs for rare diseases, or orphan drugs. We don't actually have an orphan drug designation in Canada, but I'll refer to them as orphan drugs. We've been trying to fit drugs for rare diseases in our same system of health technology assessment and reimbursement and evaluation. And maybe that worked for a little while when there was 2 or 3 drugs and we could just pay for them. Unfortunately, that's not working anymore. When we start looking at rare diseases specifically, and specifically genetic diseases, we're talking about 5% of live births have an early onset genetic condition. There are estimated to be about 7,000 rare diseases, which account for more than 50% of pediatric hospitalization costs. And there are also now becoming rare variants of common diseases. So we're starting to salami slice the common diseases into rare variants of common diseases, which allows for the development of drugs with an orphan drug designation, which comes with some benefits as well. So we have to ask ourselves, and I think the answer to this is yes, are we getting some social value over and above what we would value some of the treatments in common diseases by treating rare diseases? The key challenges are trying to find ways for patients to get access to effective therapies, access to a timely diagnosis, and trying to make evidence-based decisions in an environment where the evidence isn't as good as what we would normally use to support decisions around common diseases. So this evidence challenge, we're often dealing with small samples and randomized controlled trials. We don't have really good natural history models to know what happens to these patients if we don't treat them. Often difficult to recruit patients into randomized controlled trials because they just want the treatment. That's what we have to use to support our decision. We can't sit around and wait for a better randomized controlled trial because there's not going to be one. We have to find better ways to use the evidence and be more comfortable with the evidence that we have. Otherwise, it's going to be a barrier to patients being treated. So the question is, does this lead to a lower evidentiary threshold for market authorization and notice of compliance? Well, I would argue it absolutely does. Well, the problem is we have market failure in healthcare, and this is the fact of life that we're dealing with. In a perfect market, there's no market power on either side. We make our own decisions. There's no imbalance of power. We have balance of information on both sides. The individual decision maximizes the utility, and we get revealed preferences, so we only buy what we want to pay for. And if it doesn't give us that improvement in quality of life, we don't buy it. And unfortunately, we have the distortion of the prices in healthcare by insurance. And that's kind of the number one problem, is the payer doesn't pay. It's an insurance issue. I think we're getting to the point that somebody doesn't have to pay. Although we'd like it to be that, my concern is talking to the public payers, is there's going to be more no's, given the potential budget impact. And we have no competition between health services usually, which ultimately, if there's an expectation from the public that a drug is going to be covered or a service is going to be provided, then we get these inflated prices. So, of course, what happens? We get more market pressure. You saw the more orphan drug designations, which are likely or potentially going to come with orphan pricing. We have this public-private sector conflict versus this finite budget management. What's in the budget for $500 million a year to support access for patients with rare diseases? I hope that's not just about paying for drugs. And we'll take a more holistic view on how we could manage this across different indications.